welcome back. The class is NUR 200 and today's topic is pulmonary emboli under the concept of perfusion. Things that I'd like to focus on during this video are to define what a pulmonary embolus is, to be able to tell me or articulate the pathophysiology of a pulmonary embolus, discuss the risk factors and signs and symptoms of a PE, identify diagnostic studies used in a client to determine whether or not they have a pulmonary embolus, discuss pharmacology pertinent to the treatment of a client with pulmonary emboli, and formulate a plan of care for a patient with a pulmonary embolus. Okay, there is a lot that happens to patients in-house that is done to prevent the occurrence of a PE. PE is one of those things that the patient can do great and go home, or the patient could die. So it's really nothing to be ignore. So the first thing is to identify or define what a pulmonary embolus is. So let's go back to the English language. It's got two words, pulmonary and embolus. Okay, pulmonary. Pulmonary relates to lungs. Okay, lungs, lung vasculature. Embolus is something that lodges or floats free and lodges somewhere. So a pulmonary embolus is an obstruction of the pulmonary circulation, which is going to cause a mismatch between ventilation and perfusion. The most common type of PE is blood clot. And the biggest risk factor, I'm just going to let you think about what the biggest risk factor could be for a pulmonary embolus or blood clot. If you're thinking DVT, you are correct. Other types of pulmonary emboli are fat emboli, which Ms. Joy is going to talk about in mobility, amniotic fluid, and air embolus, which can happen through IV tubing, or it can happen related to central line insertion. So there's multiple types of emboli. It's not always just clot, but the primary one that you're going to see is a clot-related or DVT-related pulmonary embolus. So what's the big deal? Okay, the big deal is a VQ mismatch. So VQ stands for ventilation perfusion mismatch. I don't know why it's Q and not VP mismatch, but that's what it is. So think about this for a second. When you breathe in and out, air goes in, air goes out. Air goes in, air goes out. Ideally, the pulmonary capillaries are doing gas exchange. So ideally, the air that goes in is going to provide fresh oxygen, and the pulmonary capillaries are going to release the CO2, and you're going to have ventilation, which is the air in and out, and then you're going to have perfusion, which is the carbon dioxide and oxygen exchange. In a VQ mismatch, let's say you have a blockage in one of the blood vessels perfusing to the pulmonary alveoli. Well, now you've got air going in and out, but you have a lack of perfusion. So they call it a ventilation perfusion mismatch. It can also be done when you have mucus plugs. You can have perfusion without ventilation. Either way, think about what happens then. If the primary place that oxygen and carbon dioxide occurs is in the alveoli, and now part of your lungs is impaired, where the carbon dioxide is not going to be released and there's going to be a problem, what is going to be your main problem? Right? The main problem is going to be hypoxia. So the most common form of PE is a blood clot. Okay, and this is a nice little thing that shows an area of venous stasis. Okay, DVTs develop, and then they end up embolizing part or all off of it, up into the superior vena cava, and through the right atrium, right ventricle, into the pulmonary artery, where it will lodge someplace in the pulmonary artery. This can be a large size embolus. It can be a small. There's a variety of them. Sometimes there's emboli on both sides of the lungs. So there's a lot of varieties in terms of what type of pulmonary emboli can occur and where they can occur. Virchow's triad was part of your pre-assignment. Virchow's triad is 3 things that contribute to the formation of blood clots. Okay? And it's important, and it's basically the physiologic basis behind blood clot formation. The 3 things in Virchow's triad, and you should already know this: stasis of blood, hypercoagulability, so an increased platelet count or increased risk of coagulation, and or vessel damage. So those three have been shown, and it can be all three, or it can be one of three, or multiple ones, have been shown to increase the risk of developing a PE. And here's an example. My folks go to Florida every year and they take the auto train, which is a 17-hour train ride. And my dad has type 2 diabetes. People with type 2 diabetes tend to have hypercoagulability related to the blood glucose. Their blood just gets a little stickier and a little thicker, so it's going to tend to want to clot more often. The 17-hour train ride, Dad would pretty much sit there for most of the 17 hours without moving. And there's your stasis of blood. So you've got stasis of blood, you've got hypercoagulability. 2 weeks after they got back from Florida, Dad was in the hospital with a pulmonary embolus, secondary to a DVT he never knew he had. Oftentimes, people who go on long trips, people go on long plane rides, are at risk for developing DVTs. And actually, there's been some things in the news where people have died from pulmonary emboli secondary to development of a DVT. It's always good if you're going to go on a long plane flight to take some aspirin ahead of time. So signs and symptoms of a pulmonary embolus. Let's think if you can reason this out, even though there's a nice picture right here. Hey, you're going to have a ventilation-perfusion mismatch, which means air can get in, but it's not going to be able to exchange carbon dioxide for oxygen. So you're going to have a hypoxic state, which means that the patient's you're going to be tachypnic, hypoxia, dyspnea, sharp sudden chest pain. Okay, you have an area that's not perfusing, tachycardia, and sometimes hemoptysis. Sometimes the increased pressures in the capillary system behind that clot are going to cause some leaching of blood into the lung tissue. So those are your common signs and symptoms. As far as diagnostics go, there's two different ways that they go with diagnostics. One is to find if there is a pulmonary embolus, and some look at clotting. So lab work in general, you're going to think about something called a D-dimer. And a D-dimer is basically a picture of clotting activity in the blood. Okay, so the higher the D-dimer, the more suggestive it can be that the patient has a clot. Arterial blood gases are going to show that the patient is hypoxic. They may be in a respiratory acidosis. If they're able to blow off enough carbon dioxide and they're hyperventilating, they may actually also be in a respiratory alkalosis. So it could be either way, depending on where the PE is and how much of the vasculature is occluded. They also may do coagulation studies to get a sense of where the problem is. On the imaging side of things, there's a couple different things. They can do a CAT scan with contrast. So they can look at the lungs and they can do the contrast to look at pulmonary vasculature to see if they're perfusing. The old standby is the VQ scan, which is done in nuclear medicine, where they look to see, basically they look to see, is there a mismatch between ventilation and perfusion. Angiography can be done, and they can look at the pulmonary vasculature via X-ray, or they can just do a chest X-ray to see the lung expansion. So those are your common diagnostics. People at risk. Think about your Virchow's triad. Anybody that has a hypercoagulable state. So people who have diabetes, people who have high platelet counts. If you're dehydrated or have a high hematocrit, you can be at risk for developing a blood clot because the blood is going to get thicker. Thicker blood is going to tend to want to clot more. Patients with venous stasis. So patients that, for example, that are going on long trips and sitting in airplane seats. And certainly unless you're in first class or business class, there's not a whole lot of room to move. So normally, if you're going to be going on a long trip, either wear some compression stockings or, like I said, take some aspirin. So go back to Virchow's triad, or vessel damage. So with vessel damage, something that I've seen a lot is patients get DVTs in their arm, in their brachial vein, brachiocephalic vein, I can't remember, because of a PICC line insertion. So that vessel damage starts an inflammatory process, and in that inflammation, platelets start to go to that site. Other states that can cause a PE, you'll see a picture here of a fracture, probably a fractured femur. That could be a humerus, I guess. And long bone fractures, there's a risk of a globule of fat from the bone marrow that can get into the system and go up to the lung and cause a pulmonary or cause a fat embolus. Treatment is going to be different for a fat embolus than it is for a PE. And you're going to learn all about fat emboli under mobility, which is on week 6. So, treatment, right? Whenever you see a prioritization question, okay, look and see, number 1, is there an airway issue? Okay, airway, ABCs, you have a hypoxic patient. So that tells me right away that the first thing I need to think about is airway breathing and also circulation. So, supplemental oxygen, okay, sitting the patient up to maximize lung expansion, okay, making sure that they have stable vital signs. And I've seen patients with PEs be sitting up, awake, and talking, and we're coding them the next minute. And they're young, like a 40-year-old woman was the one that really got me. So prioritization is making sure the patient's oxygenating, they have a blood pressure, they have a heart rate. Longer-term treatments is we need to prevent further clots from happening. It's rare that they're going to give somebody a thrombolytic like TPA, because the problem with thrombolytics is it's going to break apart every single clot you have in your body, which means that if there's a venipuncture for lab work, they're going to bleed out of that. They're going to bleed out of every place you can imagine. So they'll usually do anticoagulation, let your immune system take care of the existing clot, and they'll put you on heparin IV or Lovenox for a period of time, followed by Coumadin for about 6 months to prevent the occurrence of future clots. And meanwhile, they'll look to see if this was an isolated occurrence or if it was a long-term occurrence. Surgical options include something called a greenfield filter. If someone has had a history of multiple PEs, they may end up with a greenfield filter, which will capture clots in the vena cava prior to them going up to the lungs and causing more trouble. Considerations, the biggest one is prevention. That's why so many patients in the hospital are on sub-Q heparin and Lovenox, is because they're preventing DVTs. Patients that are on bed rest should have compression or pneumatic compression stockings or PCBs. They should also be possibly doing some range of motion, and you should be monitoring to make sure they're not developing a DVT. Another one is ABCs. If the patient develops a PE, remember, you have a hypoxic client. That's got to be your priority nursing intervention. Decreased cardiac output can occur because blood is all stuck up in the lungs, which can cause a problem. Ineffective protection. You have a patient on Lovenox or Coumadin. Now you've developed another problem that the patient's not going to be able to clot. So that goes into teaching topics along the lines of bleeding precautions. Thank you very much for your time and attention. And I have a case study that I would like you to do related to pulmonary emboli. Thanks.